Good afternoon, everybody, and welcome to the teaching webinars of NursEduPal IMPACT. This second series focuses on topics that are important for clinical leadership in palliative care. We hope that when this webinar series is completed, you will feel strengthened in your palliative care attitude. I am Dani Breke, and I'm the coordinator of the NursEduPal IMPACT project. I'm also the research coordinator at the School of Nursing of West University of Applied Sciences in Bruges, that's Belgium. Before I introduce our speakers of today, I would like to remind you that all the webinars as well as the presentations used are or will be available soon to our project website, just as Patricia told you a few minutes ago. I would also like to remind you that the information that we share with you is not at the specialist level, but at the generalist level. So it is accessible and suitable for a broad group of healthcare providers. Through our website, we will soon share impact tools to help you increase your self-efficacy in the topics that are discussed in the second series. As such, we hope to bring you one step closer in becoming a palliative care influencer. It is my pleasure now to introduce our two speakers of today, Gerda Okerman and Heidi de Floor. Gerda Okerman is a nurse with a master's degree in medical and social sciences. She is an author and co-author of several books on advanced care planning, and she is the advanced care planning consultant for the palliative network Ghent-Eeklo in East Flanders. So you might expect that Gerda will talk about advanced care planning today, but she's not. I asked her to tell us about the palliative care indicators as a tool to identify palliative care needs in patients. And I asked this because Gerda is the co-founder of this tool that is widely used in Flanders, especially in elderly care. So I felt it was only right that Gerda herself would introduce this tool to a European audience. And I'm very happy she accepted my invitation. I'm also very happy that Heidi accepted my invitation to present today. Heidi de Floor is a psychiatric nurse with a lot of experience in home care. At West School of Nursing, Heidi is a senior lecturer and a coordinator of all simulation education. Heidi will talk about the importance of professional and effective communication in healthcare and introduce to you the ISBAR communication method. For the fluent progress of the presentations, I propose to keep questions for both speakers till the end of the webinar. I hope that this is okay for you. And without further ado, Gerda, the floor is yours.
Thank you, Dani. Good afternoon, everybody. I'm Gerda Okerman, and I will guide you through the first part of this webinar. I will introduce you to the indicators using a case study. The different indicators are discussed, the method to deal with them, the assessment comes next. The intervention, what you must do when you see palliative care needs, is the last part of my program. Heidi de Floor comes next. She talks about ISBAR method, a method to achieve effective communication in a structured manner between healthcare providers. But what are those indicators? We all know how important it is to start palliative care early enough in the disease trajectory. However, it remains very difficult to determine exactly when the start of palliative care is necessary. In this webinar, we introduce indicators, often small changes, tipping points, subtle changes in a patient's condition. By paying attention to these signs, we can adjust the care to the patient's new specific needs, and we can determine new goals. Those changes can manifest themselves physical, psychological, social, and/or spiritual. This is the poster we developed. The origin of the indicator was in 2015, already 10 years ago, where the Regional Dementia Expertise Center Paradox with the network Palliative Care Ghent-Eeklo, where I worked together in a project Timely Initiation of Palliative Care in Residential Care Centers. Since the introduction, there was a further development, and since 2024, the indicators are widely used in Flemish residential care facilities, home care and hospitals. Most, if not all, the indicators can be noticed by the broad care team. the nursing team, the paramedical team, the cleaning team, and even by close ones. You should never ignore them, no matter who reported them. The indicators, and now I will name them one by one, are any change or suspicion of change, difficulty of swallowing or choking, recurring infections, refusal of care or food, no new severe pathology, weight loss more than 5% in 6 months, change of care needs, end of life questions, repeating falling, dementia, and maybe other indicators. Because it's a bit boring to clarify the indicators one by one, I will explain them using a case. Not every indicator will be discussed, so I'd strongly recommend you to read the syllabus that accompanies this webinar so that you get to know them all. While telling this case, I will also use the From Cure to Care schedule, the schedule you learned about in a previous webinar. The case is about Simone. She's a very independent, 75-year-old woman, and we are April 24. Simone has not been feeling well for several months. She experienced persistent abdominal pain, loss of appetite, and weight loss. And after a series of tests, she is diagnosed with pancreatic cancer. Upon diagnosis, Simone is shocked and overwhelmed by the information she receives. She has many questions about her treatment options and worries about her future. Simone wants to know what treatments are available and what the side effects are and prognosis are. Her care needs focus on finding the best treatment options to fight her cancer, live as long as possible, and maintain her quality of life. In consultation with the oncologist, a therapy of surgery and chemotherapy is initiated. She also needs emotional support to cope with her fear and anxiety. October 24, 6 months after her diagnosis. The aggressive treatments cause side effects such as extreme fatigue and nausea. She continues to have diarrhea, and despite eating very much, she has lost 15 kilograms in the meantime. She has gone from 70 kilograms to 55. Simone is very strictly monitored. CT scan, MRI, blood tests every 3 months. Despite all results being hopeful and showing no regrowth or metastases, Simone begins to struggle with daily activities and feels weaker. She's very often tired. Simone is very worried and she wonders how to proceed. Where at the beginning of the diagnosis, her goal was mainly to live as long as possible, this is now changed to more, I want to see my grandchild born. Her youngest daughter is pregnant for the first time. Simone lingers between hope and despair. On the one hand, she wants to stay alive and see her grandchild grow up. On the other hand, she is very much aware of her diagnosis and the poor prognosis. 3 months later, January 25, the last CT scan finds a local recurrence. The oncologist suggests 6 radiation sessions. Simone agrees. Treatment is tough, but Simone does not want to give up now. She wants to be able to hold her grandchild in her arms. Extra attention is given to the troublesome symptoms Simone experiences. Shortly after radiation treatment, Lucas is born, a lovely little boy. Simone is over the moon with her grandson. And despite her joy about her grandson, Simone begins to ask questions about the end of life, about where she wants to die. In these few months, from October till January, Simone has moved up again in the From Cure to Care schedule. March 25. Over time, it becomes clear that the treatments have not had the desired effect and that the cancer has spread to the liver. After a few weeks after the birth of Lucas, Simone begins to see yellow and develops ascites. Once in the hospital, regular ascites punctures are required. As a pain treatment, Simone is given OxyContin. Simone's concerns have changed again. Although according to the oncologist there are still options such as second-line chemo, Simone now indicates that comfort has become her main desire. Notwithstanding, she has a very hard time that she will not see Lucas grow up. She does not want further treatment, and Simone speaks openly about her death, saying she wants to die at home. This dia illustrates the importance of using the From Cure to Care schedule. 1 month later, April 25, Simone comes home from hospital and her general practitioner continues the ascites punctures at home. Maximum home care is initiated. Simone is not comfortable despite optimal care. Her children insist on hospitalization, but Simone indicates that she no longer wants to go to hospital. She maintains her wish to die at home. The palliative home care is called in agreement with Simone, the general practitioner, and her children. Palliative sedation is initiated. Simone dies peacefully at home, surrounded by her loved ones. In this case, we have a patient who is very aware that she is ill and will die. Moreover, she is also willing to talk about it. The care was therefore always adapted to her changed care needs. In many occasions, however, this is not the case, and palliative care is only started in the terminal phase. The indicators help to recognize this phase earlier and to adjust the care appropriately. This care can consist of starting palliative care, but can also consist of talking to the patient about advanced care planning to determine new care goals together. The care providers must be sufficiently alert to see the different indicators so that the care can be discussed and adapted. The number of indicators that must be positive before we talk about palliative care is not fixed. It depends on the severity and the influence on the general well-being of the patient. The caregivers also have to be aware that one indicator can be positive several times, as I illustrated with the case of Simone. Each time an indicator is positive, it should be taken into account. In the diagram from cure to care I showed as I brought the case, you could see how Simone advanced from cure to palliative and terminal care. Simone had palliative care needs as early as October. She had severe diagnosis of pancreatic cancer. She lost a lot of weight. She had extreme fatigue and nausea, and she struggled with daily activities and was very often tired. Use the indicators to recognize palliative care needs in a timely manner. The indicators I did not use in this case are difficulty in swallowing, recurring infections, repeated falling, and dementia. Those indicators are more common in the frailty trajectory. In organ failure, all indicators can occur. The most important is to know the indicators, to recognize them in your patients, and to take them into account. Of course, it's not enough to recognize the indicators, then something must be done with them. If you observe one severe or different less severe indicators, it's time to assess if your patient needs an advanced care planning conversation or has palliative care needs. The first step in the assessment is the surprise question. Would I be surprised if this patient died within the next 6 to 12 months? The answer to the surprise question is intuitive. Scientific research has shown that care providers are very capable of answering this question correctly. If the answer is yes, I would be surprised, there is no immediate need to initiate palliative care. The focus remains on curative or chronic care, with an emphasis on disease management and maintaining quality of life. Regular reassessment is important, especially if the patient's condition changes. If the answer to this question is no, I wouldn't be surprised, there is a need to assess palliative care needs and consider an early palliative approach alongside any ongoing treatments. For this assessment, you can use the SPICT scale. The SPICT Supportive and Palliative Care Indicators tool is a practical tool designed to help healthcare professionals recognize in a timely manner patients with deteriorating health who might need palliative care. SPICT consists of two main sections. The general indicators, those include signs of progressive decline, frequent hospital admissions, increasing dependence, and persistent symptoms despite treatment. And the clinical, specific clinical indicators, those focus on organ failure, neurologic conditions, cancer, or frailty-related decline. This decision tree helps you to identify the patient with palliative care need. First, you've seen several indicators. Second, you ask the surprise question. If you can say, yes, I would be surprised, your patient has no immediate palliative care needs. But if you wouldn't be surprised, you look to the general indicators. If there are two or more indicators, you look further to the specific clinical indicators. In general, I recommend involving a general practitioner in this as well. If there is only one clinical indicator, your patient has palliative care needs. Any member of the broad care team, including the close ones, can notice indicators. Do not allow them to slip away into the daily routine of care. Make sure everyone knows to whom they have to report if they see an indicator. After noticing one or more indicators yourself or after being informed by someone else, and you have a positive SPICT, you can discuss with the team or the physician whether they are reasons to start or are just the palliative care approach, advanced care planning, end-of-life discussions. Being alert for the palliative care and advanced care planning indicators is an opportunity to review goals of care and adjust overall care. But how can you implement this, the indicators and the SPICT, in your practice? On the website, you can find the explanation of the indicator bingo and the Find Your Match exercise. But the most important is to combine the 4 tools. And they don't want to occur. The 4 tools, yeah. The 4 tools that you have taught during this webinars and use them in your practice. Those 4 tools are the poster with the indicators, the use of SPICT with the decision tree, the illness trajectory, and the From Cure to Care schedule. You can use them in communication between colleagues, but also to start a conversation with the patient or his family. This was the first part of this webinar about the indicators. And before I turn the floor over to Heidi, I want to thank Danny, because by almost twisting my arm, and now is my text gone, by almost twisting my arm, she encouraged me to work out this lesson. She has become a special colleague and by now a good friend. Thank you, Danny. And now Heidi, oh no, Danny, it's all yours.
Thank you, Gerda. I'm very glad I have this effect on you. And since the whole series that we are doing at NursEduPal IMPACT is about self-efficacy. I'm glad I could contribute to the increase in your self-efficacy. As I thought, you did a great job in presenting the palliative care indicators to us. I think indeed that combined with the disease trajectories, the cure care scheme, and the SPICT, that you have a very nice set of tools to assess the condition of your patient. And I hope that our community of nurses will feel, and other healthcare providers will feel that these are valuable tools. I'm trying to keep on talking until Heidi is able to share her screen.
I think I have problems presenting, and Teams doesn't want to do what I wanted to do. So I'm trying, Danny, keep talking.
Okay, so we could now, if I would be Veerle, we would probably do a bingo now, trying to recognize the palliative care indicators in any story. Heidi, you could also just share it in a normal way, maybe?
Yeah, I'm trying. Just 30 seconds, I think. I don't know what's happened, but I'm here. Just a second. I think it will work now.
Okay.
No?
Not yet.
Not yet. How come? Presenting and Teams. Trying and Teams. That's always the same thing.
We don't see
No,
your
it
screen.
doesn't. No, it doesn't come.
No. Maybe just share your screen.
Yeah, I will do that. But that's
You have two screens?
yeah.
Okay.
Oh no, the nerves are getting in. That's not good. And we tried it.
Yes.
And it all worked. I'm so sorry, people. And now, are you seeing?
No.
No, not yet.
But we maybe can try, Heidi, because I have the presentation, that I can try and share it. And then you just have to tell me next slide, next slide.
I will share my screen, and if that doesn't work, then you can do that.
Okay.
No, it doesn't want to. And I don't know what happened. It started. Here we are. No.
Yes.
Can you see it?
Yes.
Yes.
So I am very happy to give the floor to Heidi who will tell us everything about efficient communication using the ISBAR tool.
Well, everything is a big saying, but we will talk about ISBAR, and I will explain to you that ISBAR is an acronym for a communication tool that promotes structured information exchange. I will talk about why ISBAR is essential in healthcare, what the basic principles are, who uses ISBAR, when it can be deployed, where ISBAR is being applied, and how it can be used in everyday communication. ISBAR is designed to structure communication, and it ensures that essential information is conveyed in a clear and systematic manner. What we want is to have an effective and safe care environment. This structured approach contributes to it, resulting in better care. So proper transmission of information about the patient is crucial as it ensures continuity of care and can prevent errors. We all want that our communication has high standards because we are nurses. ISBAR plays a key role by ensuring that we meet following criteria. At first, security. Ensure that only accurate and objective information is shared and that confidentiality is maintained. Second, effectiveness. The information should be appropriate and understandable to the recipient, depending on their role and expertise. Also, relevance. The information should be relevant to the situation of the patient and the decisions to be made at that time. And at last, repeatability. Information should be given in a way that can be repeated so that others can also be informed. By following these criteria, healthcare providers can ensure they communicate effectively, save time, and ultimately resulting in better care. It's important that you take a moment to consider your data transfer before you start communicating. As a nurse, we all know that well-structured transfer is crucial for the continuity of care, and it can prevent errors. So a little exercise to keep you awake. Is this true or false? You can put your answer in the chat, and because of my problems with the PowerPoint, I can't see the chat. So Danny, it's up to you then.
Yes.
All available information of the patient must always be shared. What do you think?
I'm looking at the chat. False, wrong. That's the two questions. No. So we are going wrong.
All wrong?
Yes, for the moment. No corrects. Yes.
Okay.
False, wrong,
so,
false.
Everybody is right. It's indeed not true. It's in the little words. The information must be relevant to the situation of the patient and the decisions that need to be made at that time. To which criteria does it belong? Make a choice. You can put it in the chat too. Security or effectiveness? We have it about accurate information. Does it belong to security or effectiveness?
I'm looking at the chat.
Yeah.
Nothing yet. It's a difficult question.
It's a difficult question.
Effectiveness, security, security. So we have a 2-2 for now. That's all for the moment. Come on.
But I have other questions. No, not need to worry. Okay. It's security.
All right.
We have to ensure that only accurate information is shared and that confidentiality is maintained. If we talk about...
just a second. I see from Cindy that she cannot see the presentation, but I think she might be the only one for the moment because everybody else is answering. So I hope they can see the presentation. I can see it. Does everybody, or can people see it? Maybe put like a thumbs up in the reactions. Okay, Mina Lisa can see it. Guillermo can see it. So Cindy, it might be, I have things coming up, thumbs coming up. So Cindy, it might be something with you, with your settings that is a problem. And I don't know from our side if we can fix that.
Should I stop the DIA presentation and start over, or?
I wouldn't really do that because it was a bit problematic.
Yes, it is. But I know Cindy, I think I know who she is, and I will give you the PowerPoint, Cindy. I will send it to you in a mail.
Yeah. So Guillermo did give a suggestion to Cindy to maybe get back in. Oh, she did already try several things. But she thanks you, Heidi, for sharing. the slides. We will share them with everybody, of course. So, okay, back to the question. It was effectivity, security, I think the first one. Yeah.
Yes, and the second one, to be understandable for the recipient. Where would you put it?
We have effectiveness.
Mm-hmm.
Again, effectiveness.
Right.
Again,
as I said, the information should be appropriate and understandable to the recipient, depending on their role and expertise. So it's effectiveness.
Yes.
And the last one, objectivity.
Security. Effectiveness, effectiveness. Security. So it's a 2-2 for now.
We will put it next to security because next to accurate information, it also has to be objective. But the most important thing is that we try to be objective and be accurate. ISBAR is a communication method based on 6 steps. 6 steps, each of which is denoted by the first letter of the acronym ISBAR. In the following slides, I will explain what kind of information belongs where. This is how we can always bring the same structure to our story or information we want to share with other professionals, family, or patients. The first one is identification. Who is it about? Indicate who you are and which patient is involved. Who's calling? Mention your name and your first name, your function, for example, home care nurse of palliative support team, and your workplace. Which patient do you want to talk about? His or her name, date of birth, residence or ward and room number are important, so the people you talk with know who it is about. The second is situation. Give a brief description of the problem. What is it about? What's the reason for the communication? Like, I worry about the pain of my patient. What's the patient's condition? Use parameters, objective information, the mental state of your patient, the pain, for example, a 6 on 10 or on the NRS scale. We cannot forget the background of our patient. It's also important. What's the patient's medical history? State the diagnosis, history, and medical treatment. What was the reason for starting care? Mention the date of startup and the reason for admission, operation, home care, or whatever your patient needs. Any relevant previous history should be mentioned. Diagnosis, relevance of previous studies or examinations, treatment restrictions like allergies, DNR code, or pregnancy, and add any relevant medication. The current medication policy, but also the home medication. Any additional information that's relevant to the situation, like living situation or significant relatives or loved ones who are involved. The assessment. In the assessment, we provide an evaluation or an assessment of the current situation. What's the problem according to you as a professional nurse? What do you think is causing the problem? For example, I think the problem is neurological or respiratory or circulatory. Give your interpretation of the observations and parameters. Your analyze, your interpretation of the examination results. For example, the CRP is raised and there is also a fever and our patient is confused. Maybe this is caused by an infection of the bladder. What is your urgency assessment is also important. Is the patient stable or unstable? Set the priority. Is there a life-threatening or a critical condition? Mention also the actions you already taken, like oxygen administration, an infusion, blood sampling, urine culture, pain medication, and did the patient already change his behavior due to your actions? In the recommendation, you specify what you want to happen, when and by whom. What do you think should be done and when? So what action is really needed? State clearly and concretely what you expect from the other healthcare provider, the physician or another nurse or a therapist. What do you think should be done and by whom? Ask or suggest what you can do yourself in advance. Also mention or ask in what time frame this is required. Right now, within 10 minutes, in the course of the day, and how often are the actions needed? So, this was a brief explanation of the ISBAR method. And readback, you don't always need to do the readback. If you take ISBAR as an information gatherer tool, you don't need to read back. But if you use it for communication with another nurse or a physician, it's important that you repeat the agreements made out loud. Repeat the orders you received. Clarify where necessary. For example, how often should the parameters be checked, or what blood values need to be determined, and record the following contact. When does the physician or specialist nurse or other care provider visits the patient? And when should you call back for an evaluation? So check and double check is very important. I want us to do a little exercise. So this is Charlotte. Charlotte is a former school director. She's 64. She lives in the city with her husband, Louis, and they enjoy their retirement and look after their 4 grandchildren every Wednesday and Friday. Just before her 65th birthday, Charlotte was diagnosed with an aggressive tumor in her left lung. 2 weeks after the operation, Charlotte is still in a lot of pain as a result of the operation. Before chemo and later radiotherapy, the oncologist proposed to Charlotte to have a conversation with someone from the palliative support team. In the meantime, the palliative support team visits Charlotte on a regular basis and supports them and the home care nurse. Now the exercise. In this exercise, the nurse calls the physician about Charlotte and she used ISBAR. Can you assign the correct lines to the 6 correct parts of ISBAR? I put numbers to them, and you can put the numbers in the right following in the chat, please.
I think we need to give people a little bit of time. Yeah.
We need to read it. I'm so glad, Annie, that you can help me because I can't see anything of the chat. I can't see nobody.
Nothing yet.
I will give a little tip. It starts with 5. Good morning.
Oh, we have one answer by Mina Lisa. 5, 6, 4, 1, 3, 2.
Thank you, Mina Lisa.
I had started and I have another order already. So
the main thing is that we can structure our information, but if we want to put it in ISBAR, we have a specific structure that you can use.
So I have two same things by Herda and myself. 5, 1, 6, 4, 2, 3. And Bart said that number 3 is the recommendation.
Okay, maybe I will put it on screen. So I will read it out loud.
We have two more. Yeah.
Good morning. This is Charlotte's home care nurse, 64 years old, who lives in the city center. That's Charlotte. I'm concerned about Madam's pain. Mrs. Vaz is 7. Charlotte is guided by the palliative support team after recurrence of lung carcinoma. Given that the pain has been increasing for the past couple of days, I think the pain medication is insufficient. In the meantime of adjusting the pain policy by the palliative support team, can I administer extra medication? And the readback is so I can start MS Contain 2 times a day. Thank you. I will pass this on to the palliative support team. So this is an example of how to use ISBAR like in a phone call. To which step belongs the question? So we had an example, but what is the problem according to you? We can't get enough of it. We have 2 little questions. To which step belongs the given question? Put it in the chat, please.
Okay, we're waiting. We have Patrick that says assessment. I think assessment too. Number 1, so assessment, but also says assessment. The people seem to agree that they think it's assessment.
I think the people are right. It's assessment. The next question, what is it about? Where do we put that? So when the assessment
Cindy says background, Patrick says situation. I also think situation. Olha says background. Cindy thinks situation. Sophia says thinks background. So there seems to be 2.
Yeah.
Background or situation.
I think it's also situation, because in the situation you give a short description of the problem.
And in the background, then it's like the previous things rather.
Yeah, it's like an anamnese. It's about what happened in the past and what's important to know to get to know your patient. Like if your patient has diabetes or something, you put it in the background because it's very important to know, to see the whole picture of your patient. Also the medication, the whole medication, for example. ISBAR is a valuable communication method that can be applied in various healthcare situations. It's used when reporting changes in a patient's condition, giving new instructions, or sharing important information with other caregivers during handover, at the end of a shift, or during transfer of care between different healthcare providers. During handover and transfer of care, it's useful as a structured method of transferring all relevant information about the patient from one healthcare provider to another. This reduces the risk of misunderstandings and improves coordination of care. If you use it when reporting an incident, it is a methodology, that's a difficult word. For reporting incidents, you are creating a clear and concise description of the event. This facilitates incident analysis and corrective actions. On our daily communication with patients and family, to communicate with patients and family about their health status, treatment plan, or prognosis. The clear structure of the method ensures that all important information is shared and understood. And when we are part of a team, multi- and transdisciplinary consultation, for example, you can use it to structure and discuss the different perspectives of different healthcare providers and consultation participants. It promotes the efficiency and the quality of decision making. So we can say that reporting and communicating information in a structured and efficient manner is an important skill for all healthcare providers, regardless of their specialization. During meetings where healthcare providers from the same or different disciplines come together to discuss the care of a patient, uniform communication is crucial. The use of ISBAR contributes to this unambiguity. You can make the match, so I take care of you. You have lots of exercise with me. Uniformity in communication ensures that team members can quickly identify and understand the information they need. Where would you put it? By clarity and structure, efficient information transfer, or continuity of care?
I keep my eye on the chat. Number 3, continuity. Okay. Bart also thinks 3. That was Herta before. Olga also thinks 3. I think 2. So Farene also thinks 3. So 3 seems to be the winner for the moment.
Yeah.
Another 3. Yes,
But
everybody thinks 3 except me.
But I think you're right, Danny. It's with efficient information transfer. All team members understand and use the same structure, reducing the likelihood of misunderstandings. But about the other two, there's also something to tell about them. But uniformity in communication has many advantages. What does it all provide? I give you 3 possibilities, but it can be more than one. So you can choose and put your answer in the chat.
Okay. Nothing yet. Herda thinks 1, 2, 3. Andrea says clarity and structure. Nobody else. Olga also thinks all 3. Bart also thinks all 3.
I think all is right. You're all correct. Besides efficient information transfer, we provide continuity of care. It increases patient safety by ensuring that essential information is not lost or misunderstood. And it gives clarity and structure to our communication because all team members understand and use the same structure as we told. So it reduces the likelihood of misunderstandings. And everyday communication, ISBAR can generally be applied during any situation where structured communication between healthcare providers is essential. It provides a common language and structure that facilitates the transfer of information regardless of the care setting. It gives us a common language. The method is widely applicable in various care settings, such as hospitals, residential care centers, home care, and ambulatory and specialized care. Some tips to be a fully prepared nurse. The reason for the referral should be perfectly clear. Preparation is essential. Have written prepared questions and observations when necessary. Collect all important data in advance, such as lab and test results, EKGs, medication lists, vital parameters before you start the communication. Take notes and write down any instructions. ISBAR works best when both parties use the same frame of reference. So, anyone can use the ISBAR method to ensure structured communication. Try to be alert to it during your daily information transfer, so we all fit into the picture of the well-prepared nurses. And on our IMPACT website, you will find the syllabus and the e-learning about ISBAR, also the fill-in form of ISBAR to use in daily practice. I think that's the end of my presentation.
Thank you very much, Heidi and Gerda, of course, also for the very nice presentations. I know we are maybe running a little bit short of time, but still I would like to give you the opportunity to share any thoughts or questions you might have in the chat, so we can present them to our speakers of today. And maybe I want to say also that the syllabi are not yet available on our website, nor are the impact tools, but very soon we will start publishing our resources on our project website. So just bear a little bit with us still, give us still a little bit more time, and then we will have all materials there. First of all in English, and then in a little bit later time, we will also provide the information in Dutch, Romanian, and Finnish. So we have thank yous coming in. Everything was clear and enlightening, so that's nice to hear. I don't know if there are questions for our speakers. People are happy that we are sharing, so that's good. Bart gives us a woo, 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 so that's nice too. If there are no eminent questions at this moment, you can always contact us through our project website. There is a contact page there, so if you have questions popping up later, do reach out to us, and we will answer your questions as soon as we can. All right.